Yeah, merci beaucoup. C'est justement. Mesdames, Messieurs, unfortunately my French is not so good, so I have to speak in English. This is our helicopter pass at the University Hospital in Frankfurt. It looks beautiful, I can tell you. But I wish that you never land there, because if you land there, you have a problem. And obviously, we don't want to have problems. These are my conflicts of interest. And what I'm telling you today is evidence-based. It's real data. And you can basically rent me, like rent a car, rent Kai, but you cannot buy me. So what I'm telling you today is just honest and pure science. I would like to start with you on a journey. And I know that there was always some conflicts with France and the United Kingdom in the past. But anyway, so the Queen died, and Prince Philip, he died as well. And Prince Philip, he had to have surgery when he was over 90. And he had to have a hip replacement. And I'm asking you, what do you think? How was his hemoglobin before surgery? Was this wonderful French red wine glass, was it full with hemoglobin? Or was it half full? Or was it half empty? What do you think? Over 90, it's probably half full, half empty. And the reason why I'm showing this is very simple, because we have fantastic data for elective surgery, because hip replacement is usually elective surgery. And what you can see here on the x-axis is, if the patients have no anemia, and these are 158,000 patients undergoing any kind of surgery except cardiac for elective purpose, and you see on the y-axis 30-day mortality. So if they had a normal hemoglobin, the mortality rate was less than 1%. However, if they had only mild anemia, so a hemoglobin between 9 and 12, then mortality rates increased by a factor of 5, and it was a hemoglobin less than 9 by 13. So who of you anesthetized in the last 4 weeks patients with a hemoglobin of 9 to 12 for elective surgery? Be honest. Everybody. So, okay, everybody does it. Did you tell your patients they have an increased risk of dying 5 to 13-fold? Who did this? You should. In Germany, we have 3 court cases now where the surgeon is under trouble because there's one solicitor, he's strongly supporting PBM, and he's saying it's common knowledge now, you can operate patients for elective surgery with a hemoglobin of 9 or less or whatever, but you have to tell them about the rest. And this will come in Europe, I can tell you. Anyhow, this is now the journey, and I call it the so-called ups and downs of hemoglobin concentration. And you see on the y-axis here the hemoglobin concentration, 12 WHO, this is for women, and 13 for men. At the bottom you see time. And you see a lot of factors, and just to prepare you, whenever an arrow is blue, that means hemoglobin falls, and if there's a green arrow, hemoglobin potentially can increase. And I guide you through. So my favorite slide is this work from the Bill Gates Foundation. They were studying the 30 major healthcare problems of humankind. And number 1 in the world is back and neck pain. Who had back and neck pain once in your life? You see? Everybody. So what does it mean? Statistics are right. They're not lying. But you see, number 4 is iron deficiency anemia. But if you go for all forms of anemia, there's not only iron deficiency anemia, this is 1/3. But 2/3 are other causes. And suddenly, anemia is the biggest problem of humankind. And estimation is that 2 billion people are suffering from anemia. This is every 4th person in the world. The biggest problem. And you have to declare as anesthesiologist the disease of anemia as your disease, because you have to treat it. We take over. Right. So the patient has problems, obviously, and goes to the GP. The GP does some diagnostics and found out a diagnosis, and the patient needs treatment. But the first thing is that we all are aware of that women and men are different. And different means, on average, women have a less body weight, less blood volume, and a lower hemoglobin concentration. Men, higher body weight, far more blood volume, and on top, a higher hemoglobin concentration. So if these people undergoing surgery, they are not the same anymore, but we do everything the same. So we have to learn, I'll show you later, we have to learn that men and women need different preparation. So the GP and does some diagnostics, and suddenly we find out that the patient is also in his normal life a blood donor. And usually you donate half a liter of your blood, women as well. But suddenly the patient needs surgery but is anemic because of donating blood. What can we do? And I know in France you have a law that patients for elective surgery need to be seen some days before the intervention. So we have it in our hands to diagnose, is there anemia and the cause of anemia, and we can treat it. And we have established this over 10 years ago, an anemia walking in PBM clinic in Frankfurt, where patients can come, where our surgeons sending their patients to us, or we're going to the surgical departments and pulling our own patients over to treat them. And this is our algorithm. This algorithm of anemia management is now version 5.0. And this treatment algorithm is also the algorithm of the German PBM network. So it's been used in many hospitals in Germany meanwhile. What you can see is on the left side, any emergency, we don't care about hemoglobin, patients will obviously be operated. However, if we have a planned surgery or planned intervention, we are interested in one thing. What is the transfusion probability? Is it less than 10%? You can see here, the patient will be operated. Is it more than 10%? We would like to know from the patient the iron status and the hemoglobin concentration. So, is there an iron deficiency anemia, so ferritin less than 100 or transferrin saturation less than 20%? The patient receives IV iron and undergoes surgery. If we have no iron deficit, we're interested in, is the hemoglobin higher than 13 for men and women? If it's not the case, we send the patients to our colleagues from internal medicine for finding out whether there are other underlying causes. So it's a very simple pathway, very simple to follow, and it works. And I show you a little bit now what happens. So you have prepared your patient, you have treated anemia, the patient is awaiting the big day. The big day is now surgery, and we all know surgery is always associated with blood loss. And what does it mean? If we follow the WHO anemia definition, men 13 gram, women 12 gram per deciliter, and you see, as I told you, men have far more blood volume, 6 liters, for example, versus 3.5 liters. The surgeon comes with his scalpel, operates, heals the patient, cuts out whatever it is. The patient is healed, but the patient loses 1.5 liters of blood. And the result is the man has a hemoglobin of 9.8 and the woman of 6.9. And that leads to a transfusion. That is basically the main cause of transfusion in hospitals, unfortunately, for women. So we have changed this some years ago and have changed the WHO definition to the Frankfurt anemia definition. And we are not allowing women anymore to undergo surgery as a hemoglobin of less than 13. You can see here. So the same procedure, women 13 of hemoglobin, blood volume 3.5 liters, loses 1.5 liter doing surgery, ends up with a hemoglobin 7.5, no transfusion. This can be very often achieved because we see a lot of iron deficiency anemia. So we have to learn as anesthesiologists, in particular, put focus on women for elective surgery. And they will remember you. They will remember you that you have done a treatment course to prepare them for major surgery. So it's self-fulfilling prophecy. So I summarize, preoperative anemia is associated with 22% longer hospital stay, a 2-fold increased risk for infection, a 4-fold increased risk for kidney injury, a 3-fold increased risk for mortality, and a 5-fold increase in transfusion. So if you put this together, this is so many complications, potential complications for patients, and it's associated with so much money. Unbelievable. So a few euro to treat anemia, it's ridiculous. So now we're coming, the big day, surgery is done, we have blood loss, whatsoever. So what can you do? And I'll show you later the new recommendations of the European Society of Cardiology. We use blood salving devices, and the way it works, you take wound blood, it's been sucked into a cell saver, washed, and then later you can retransfuse this blood. And we all know the patient's own blood is the best blood. There's a small company, a French company. I have to say I'm really proud of this company because they built a game changer. And you will find this company also here outside in the industrial area when you go left, right. They have built a machine which not only can wash red blood cells, they're also able to wash platelets. And the platelets are working. So this is a new, really powerful alternative for our daily practice. So I highly recommend this new device and system to implement in our daily work. Okay, so we have done the right things. We have even taken wound blood. We have washed it. We have given back to the patients, blah, blah, blah. And then the patient, after one day, is out of our sight. It's out of our hands. It's not anymore in one of our monitor units and goes back to the surgeon. And before that, you could do something. There's a nice trial out to treat post-operative anemia 1 day after surgery. This was a study with 200 patients. And one group received iron IV, the other one standard therapy. And the outcome was, and I'll show you just the last 3 one, if you have even 1 day after surgery treated the iron deficit, it led to a reduction in RBC transfusion the red blood cell transfusion, from 6 to 1%. The perioperative complication rate from 14 to 2%, and the hospital length of stay from 11.6 to 7.8 days. So even 1 day after surgery, anemia treatment works. So the patient is now on the surgical unit, and usually in the surgical unit, the youngest trainees are on duty, and they are very often a little bit frightened whether they're doing a mistake. So they take a lot of blood just to make sure they're not doing anything wrong. However, you need to talk to your hospital. And what we have done about probably 12, 13 years ago in Frankfurt, we have changed these tube collection tubes and asked the company not to change the outer part, because it's all been done by robots in the laboratory. But they changed the inner part, so we take less than 50% now of the blood of the patients. And that translates, for our hospital, we take every year less than 2,000 liters of blood from our patients. 2,000 liters, so it's 2 tons. It's like an SUV, a big SUV. And that saves the patient's own blood, but also we save money because this is highly contagious wastage. It needs to be burned, and this goes by weight, so we're saving money as well. We're saving money and saving the patient's own blood. So coming to a very important point, when you talk to your patients and you are explaining to them you might get transfusion. And if you asked worldwide doctors, 100 doctors, 99% will answer, I will tell my patients the risk of HIV and hepatitis C to attract from transfusion. But let me tell you, in the Western world, there's a higher risk to die of lightning than attracting HIV or hepatitis C. What you have to tell your patients, going to the right side, is the risk of allergic reactions and TACO. And TACO is transfusion-associated cardiac overload, and this is a chance of 1 in 100. So if you transfuse 100 patients, at least one patient will have these complications, and we know if you have a TACO, the chance that you're dying is high. So this is what you have to tell your patients. So I'm summarizing now the study results. We have done some years ago a big PBM, perioperative PBM program trial with 4 university hospitals, Bonn, Frankfurt, Kiel, and Münster. And we did a very simple thing. We have enrolled 55,000 patients before we started patient blood management in Germany and in these 4 hospitals. And then we trained the hospitals, we trained staff. We did 3 things. We optimized preoperatively hemoglobin concentration. We used blood-sparing techniques. And the third one was we had a standardized transfusion protocol. And then after the training period of 3 months, we studied 75,000 patients. And the results were really impressive. We had 20% less transfusion, and we had 0.2% less complications. So really, really powerful. We looked also at the money, and I can tell you, we saved money, and we can translate it nowadays into hospital beds. If you're a hospital with 1,000 beds, you save per year roughly 1 million euro every year in direct cost. And also now at 2019, we are transfusing in patients 50% less red blood cells, 50% reduction. And this is our latest data from last month. These are the data from the German PBM network trial. We are celebrating now 10 years of this registry. And we enrolled 1.2 million patients, and I'll briefly guide you through. In this network, we obviously followed the 3 columns of patient blood management: anemia management, blood loss minimization, and rational use of blood products. And in the next slide, you see on the right side the different surgical disciplines. And I will summarize it for you. We managed in these 1.2 million patients that we were effective with our PBM program. So we had less RBC transfusion rate, we had less days in the hospital, and we were safe. There were no more complications, and mortality did not change. So this is now really another landmark trial demonstrating how important patient blood management is. And this is one of my final slides now, demonstrating that even the European Society of Cardiology, they have updated their guidelines last year on cardiovascular assessment and management of patients undergoing non-cardiac surgery. And this is worldwide probably over 80% of all surgeries. This is what is covered here. And obviously we were also involved as ESAIC, and we managed to get a chapter in which did not exist before. And that is chapter 5.5, patient blood management, on pages 44 to 46. And I'll just summarize it for you. It is recommended to measure hemoglobin preoperatively in patients scheduled for intermediate to high-risk non-cardiac surgery. That's the 1B recommendation. That's one of the highest you can achieve. But the even better one is coming now. It is recommended to treat anemia in advance of non-cardiac surgery in order to reduce the need for RBC transfusion. And that is 1A. So what it says is you should look for anemia, and if there's anemia, you have to treat it. That is the recommendation. And this guideline is probably one of the most read guidelines in the world. And they also, for our field, very interesting, they also have one recommendation in patients undergoing surgery with expected blood loss of more or equals 500 ml, use of washed cell salvage is recommended. And that is a 1A recommendation, the highest recommendation possible. And then it's recommended to use point-of-care diagnostic for guidance of blood component therapy when available. And this is also a 1A recommendation. So I'm really proud of this, and it really puts us as anesthesiologists in a new position, an absolutely new position of improving patient outcome. And finally, Barmer Healthcare is the second biggest healthcare insurance in Germany. We have over 10 million customers, and they have written the Barmer Hospital Report, and they took their own data. So they have over 10 million customers, and they have a database from 15 years, and they analyzed everything, and they came to the conclusion PBM is safe, PBM is good, and now they signed a contract with 4 university hospitals. They will pay diagnostics, they will pay therapy, and they give us extra money. And when the pilot is over, the other insurance companies in Germany said they will join them. So in the future, I think maybe in 2-3 years, PBM is standard of care for in Germany, and very likely, if we are clever enough, it's our new job, and it will be well paid. Ladies and gentlemen, mesdames.